Sending love, health, happiness, and prosperity to you watching this video. Welcome back to my channel. I'm Dr. Aisha, a family nurse practitioner. And in this video, I'm going to give you my take on which nursing I think is harder, ER or med-surg. So, I have my son with me on this video. He is beginning to teeth, I believe, so he's just playing, so he'll be hanging out with us. Okay. So first off, I want to preface this video by saying I want to include ICU, although I've never worked in ICU. But I'm gonna just kind of say I think med-surg is harder, and I'm gonna tell you the reason why. So before I became a nurse, I was a scribe in the emergency department, and I absolutely loved it. I knew I wanted to do ER nursing. So I went to nursing school and I did an accelerated program. Check that video out if you have not. And in my program, I was with the same preceptor for the entire year. And it was a 1-year program. And I was on med-surg and I absolutely hated it. I did not like it. It's so different from med-surg. It's a different type of nursing. So I knew when I was in nursing school that I wanted to work in the ER. I wanted to go back. And that's exactly what I did. When I graduated, before I had even graduated, I landed a job. All I had to do was pass the NCLEX. So graduated, passed my NCLEX, and my job was a residency program. And a residency program is for new graduate nurses who have no previous nursing experience. And so their program was it 3 or 4 months. It was a critical care residency. I think it was 4 months. I can't remember. But anyway, they trained me how to be an ER nurse, and I absolutely loved it. So as an ER nurse, I had 4 patients, and they would come in for various things. And so ER nursing is very doing. You're always doing something. You're getting a new patient, you're working up a patient, or you're discharging a patient, or sending them to surgery, sending them to dialysis, sending them to the floor, whether it's ICU or med-surg, or discharging them home. So it's a lot of starting IVs, it's a lot of getting blood cultures, getting blood, sending them off to the lab. Just a lot of doing, a lot of IV antibiotics, a lot of IV fluids. So it's a lot. Absolutely loved it, right? In addition to, having 4 patients, which I think is very manageable, the patients are in a close vicinity, right? All of our rooms were right next door. All of my patients' rooms were right next door to each other. So I'm not having to, walk very far. And then the Pyxis, the machine that we get the drugs out of, it is very close as well. It's right there as well. So everything is very close. You have your physician right there. Or if they're, sometimes I did work with the emergency nurse practitioner. So the provider is literally right there. So it was great. I was able to ask a lot of questions. I was able to, already kind of know what they were going to order and start getting my labs and stuff in, getting the orders for my labs before they even put the order in, because they told me that, what they were going to do. So I like we're sending patients to getting x-rays. We're sending them to get CT scans. And then where I started in ER, the critical care area, it was separated. We had emergency, and then we had critical care, which is also part of the emergency, but we would like code patients over there. And if they needed to be on like a cardine drip or nitro drip, we would go there. And in the critical care area, we had a maximum of 2 patients because they require very close monitoring. And usually those patients are either going to go to ICU or to the morgue, unfortunately. So I absolutely love, love, love ER nursing. Now, yes, okay. I'm looking at my notes. So I transitioned to med surg, not because I wanted to, but I was in grad school at the time and I needed to cut down on my hours because I was about to start clinical. Keep it simple. I was about to start clinical. So I let my manager know. I was like, hey, can I go part-time? Which part-time is 2 12-hour shifts instead of 3 12-hour shifts. And my manager was like, no, you can't do that. You'd have to go to night shift. So I did not want to do night shift. I didn't want to do night shift. So I got another job. And the other job was on the med surg floor, and it was a transplant floor. So not particularly what I wanted, but I had to go where the opportunity was, because at that time when I was looking around for part-time jobs, there weren't too many options as far as bedside nursing. So that's what I did. So I got experience. And then, so usually whenever you're transitioning to like a different specialty in nursing, you need to do what's called a fellowship. And that's so you can safely take care of these patients. So the hospital that I went to, I did not have a fellowship. I think I had 6 shifts on the med surg floor before I was on my own. It was totally different. So I just kind of winged it. I knew how to take care of patients. It was just a different type of patient. So I did not particularly like it because it's a different type of nursing. And let me see. Yeah, so I would have a maximum of 5 patients. That's 1. And having 5 patients, I think, is hard. There are multiple hospitals out there that have way more than 5 patients. So they're like, girl, 5 patients, that's nothing. We have 6 or 7. I think that's unsafe. But I know when I was in nursing school, we would get up to 6 patients. And I would be struggling because at that point, you're trying to remember everything. You're trying to remember all your patients. And like med surg, I think it's harder because there's more to know about your people. And like now, when I go to work, I try to get there early. I usually get there early so that I can read up on my people, so that I can hit the ground running. I already know what's going on with my patient. I'm not relying on a nurse to give me a report, because sometimes nurses, they be so busy. We be so busy, we don't have time to read the notes. So I try to get there early so I can hit the ground running. I don't have to rely on another nurse's report. You know what I'm saying? Because they may say something that's not accurate. So I, check charts, check the orders and all that jazz. That's right. Yeah. Yeah. So, oh yeah. And so for ER nursing, like, you only give reports to one nurse. That's my experience. Whoever had my set of patients, that's who I'm getting report from, right? On the floor, I could get up to 5 reports, from 5 different nurses. And that's what, a lot of times, that's what keeps us there longer, charting for one, but also we have to wait on, what if this other nurse that we're getting report from, what if they have to give reports to 4 other nurses as well? So it's just waiting around on different nurses to give you a report. And then some nurses, they have all the questions. Like, tell me what the chart's not going to tell me. If I can read it in the chart, I really don't need the nurse to tell me. I need the nurse to tell me, what is it, son? Oh, bless you. I need the nurse to tell me what the chart's not going to tell me. Tell me how this patient is acting. Tell me the meat and bones. Give me, why are they here? What are we doing? What's the plan? I don't need all this extra stuff about where their IV is. Like, half the time I don't even know where the patient's IV is. I where it is. I just know that they have one and that it flushes well, and that I've been giving meds through it. Like, or tell me if there's an issue with their skin, or tell me if they're confused. Like, tell me what I cannot read. You know what I mean? So, yeah, may have up to 5 different patients or more, depending on your hospital. You may have, all those nurses to give reports to. And then, like, your patients are not going to be in the same vicinity, right, on the floor. These hospital floors hallways are long. So you may have a patient at the end of 2 hallways, depending on how your facility is. You're going to be walking all day long. All day. I know the hallways at my job, they're very long, and there are 4 of them. So the charge nurses, they do really well at trying to keep the nurses on 2 hallways, but sometimes you're on 3 different hallways. That's a lot. That's a lot to be having patients in 3 different hallways. Goodness, that's a lot. And okay. And like I said, in the ER, all your patients are right there. They're all going to have the same doctor. On Med-Surg, you may have 5 different doctors or advanced practice providers, NPs or PAs. And you have to know who they are. You have to know how to get in contact with them in case something happens, or in case you need to notify them of a change in your patient's condition. Oh, what is she? You sleepy? Okay. You have to know how to get in contact with them, at all times. If there's a rapid, if there's a code, like, you have to know how to get into contact with your patients, who their first call provider is. No, son, no. Okay, I'll put it back here. Go to you sleepy. Go to sleep. I'm getting these alerts. So, yes, different first call providers. And then the doctors who I work with in the ER, they were cool. If I had questions, I could ask them. Plus, it was a teaching hospital. So I love teaching hospitals because the residents, they love to teach. And the way I pose questions, and this is what I tell either it's a nurse resident or even nursing student, I'm like, don't be afraid to talk to the doctor. We're colleagues. They're not higher than you. A lot of times they do know more than the nurses because, yes, they've read more, they've been in school longer, they've studied more. So, yes, they know a lot more. And, the way I pose questions is, hey, can you educate me on this? Instead of saying, why did you do this or why did you order that? Like, they don't necessarily want to be questioned because depending on who it is, they may say, oh, why is this nurse questioning me? You know what I mean? So I pose the question is, hey, can you educate me on the reason for this? And usually it's great. The way that question is worded works great. I've never had any issues. And so attendings, they'll explain things. Med students, they love explaining things usually, and residents, they do as well. So it's just different, med surg, you have different providers. And we use Epic. So I use Epic Chat, and then some people don't like Epic Chat. Well, if you don't like Epic Chat, I'm going to be paging you all day, because if I have a question about something, or if this patient is nauseated and the Zofran isn't working, I need to advocate for them to get a different medication. So, I would say that. In addition, usually the patients, a lot of times in the ED, these patients are walkie-talkie a lot of the times, not all the time. On Med-Surg, you may have the patients, they're high fall risk, right? We do a lot of documentation. That's another thing why I think it's harder, is because of the documentation. We have to do full body assessments, not just focus like in the ED. The ED is very focused. So like whatever they came in for, if they came in for chest pain, you're going to do a chest pain exam. You're not going to do a head to toe. You know what I mean? You're going to listen to their heart and lungs. That's pretty much about it. You're not gonna listen to their bowel sounds. You're really not gonna look at their skin. You're not gonna be doing a virus score. You're not gonna be doing none of that. What is it, son? You sleepy? Yeah. Yeah. Okay. The documentation. There is a lot of documentation, and we get admissions on with an admission. Okay. There's a lot. There's a lot of questions we have to ask the patients. Okay. I know when I was in nursing school, they had an admissions nurse where all the nurse does, and this was only during the week, but the admissions nurse would come by and they would do the admission questions. Well, in on my unit now, we don't have an admission nurse. We have to do the admission, and you have to get it done, I think, within 24 hours of them getting to the floor. And so we have admissions, and then we have discharges. Where we have to do all the discharge paperwork and discharge teaching. And then a lot of the times, especially with transplant patients, I do liver and kidney transplant. So sometimes the patient is already they already have a diagnosis of diabetes. So they already kind of know how to check their sugars and stuff. And sometimes they don't, but they get high blood sugars post surgery because of all the high dose steroids. So they may not have been on insulin in the past, but they may go home on insulin. And then a lot of times that may be temporary. Hopefully it is. It just depends on how your body, does well with the steroids. Plus, they're tapered down. So usually they say, well, we don't know. We just have to wait and see. But, that's why it's really important to keep checking your sugar and writing everything down. So if the patient has no knowledge of diabetes or blood sugar checks and insulin administration, okay, then we have to do that teaching. Go to sleep. I know. Okay. We have to do that teaching. And sometimes y'all teaching be hard. I remember this one time I had a patient. He was an older guy. I think he wasn't too much older. He was in his 60s. But I don't know his level of education. And the reason why I say that is because when we do teaching, we have to teach them how to administer insulin based on a sliding scale, right? So the sliding scale is, if your sugar is 185, and so if your sugar is 185, the sliding scale may be if your sugar is between 180 and 200, you're going to give 1 unit. That's just an example. So this patient, he didn't know where 185 was on the list. So it's 180 to 200, 201 to 220, 221 to 250, just to give you an example. He didn't know that 185 was in between 180 and 200. So here I am writing down all the numbers in the range. Because the NPs, the nurse practitioners with the endocrine department, they'll say, teach this patient how to administer insulin. But that's easier said than done. That needs to be somebody's job. Med-surg nurses don't be having time to educate because the hospitals don't value patient education. And I'm saying that in a general sense. Because we should not, and that's what I did my doctoral capstone project on. Okay, son, I'm having a hard time. We should not have to feel like education is an extra task, right? But many times it is because it's very time consuming and we be so busy doing other stuff. But education should be a part, I think, of a nurse's practice. But many times it's just we so busy, insulin teaching, that could take up to an hour, depending on the patient's literacy and health literacy. So, man, in the ED, they don't have to do none of that. They're not doing insulin teaching, not to my knowledge, unless something changed recently. No. So there is a lot of documentation. We oftentimes have to clean the patients up. What if the tech is busy, with another patient? Because a lot of times these techs have minimum of 10 patients, and that's on a fully staffed, good staff day. what if they're busy, and then what if your patient is soiled? Then you're going to have to clean them up because you don't want them sitting in their waste. You don't want them to get any skin breakdown, and that's just not right. You want to, saying go ahead and clean them up. Clean them up. They're on fire risk. You're gonna have to help take them to the bathroom sometimes. I'm the type of nurse where I'm not gonna just delegate everything. Like, I'll delegate, but if my tech is busy and my patient needs something, then I'm just gonna do it because I don't want my patient to be without. Son, what's happening? You just sleepy. Yeah. So I think that's pretty much it. I think ER is harder. I mean, med surg, my bad. I think med surg is harder. I feel like if you can work med surg, you can work anywhere. I feel like, and you know what? When I was in nursing school, like the old school nurses would say, you need to get you a couple years of of med surg experience. And I was thinking in my head, like, no, you should be able to go wherever you want to go. And I still feel that way. But now having 6 years of nursing experience, 3 and 3.5 in ER, and then coming up on 3 in med surg, I get why they said get you some years in med surg first, because if you can work in med surg, you can manage all of these different patients. You're their manager of their care. Because everybody's gonna call the nurse. You're gonna get calls from social work, you're gonna get calls from occupational therapy, physical therapy. The doctor's gonna call you, the dietitian is gonna call you. Um I don't know who else. The nurse that's calling to give you a report on a new patient, they're calling you. The nurse who's um the patient's finna go down for a surgery, so the pre-op nurse is calling you for a report. I mean, the family member may be calling you for a report, whereas in ED, you're not having to call all these different reports. Not like that. A lot of times, family members right there in the room with them. On the floor, people gotta leave. They gotta go to work. You know what I'm saying? So they want to call in and check on their loved one for whenever they're not there. So, I get why old school nurses say get you a couple years of med surg experience, but I don't think med surg experience is necessary. I think that if you want to come out of school and go to ICU or ED or PECU, or I think you should do that. I do think you should get a couple years of bedside experience though, before venturing out into other things like being a nurse practitioner or CRNA or even case management. Just having some bedside experience, I think it helps make you a more well-rounded nurse. And just the knowledge is invaluable. I never thought that I would work on med surg, and here I am, almost 3 years in, working with liver kidney transplant patients. So, yeah, if you can work med surg, you can work anywhere. Because I feel like, although I've not done ICU nursing, I feel like I would be a bomb ICU nurse. I pay very close attention to detail, and I feel like I would have the time to do that. Um, as an ICU nurse versus having to like kind of juggle all these things. Med surg, it be rocking, like it don't stop, and you be having so much going on. So I would suggest, if you're a med surg nurse, try to get to work early so you can read up on your patients. You can already hit the floor running. You already know what's going on. You can look at their labs, look at the latest notes. That's really all you need to do, I think, as far as having take you some notes as well, because if your patient does, if there is a rapid on your patient, and when the rapid nurses come, they're gonna want to know what's going on. They're gonna want to know the history. Or if your patient starts the code, they're gonna know what's the patient's history. So like having those notes, I've had that happen before, and I was like ready. Like this is their history. This is what they're here for. This is what's going on. This is what happened. So it's just in your patient's best interest if you know what's going on with them versus if you don't know. Because trust me, I get it. So yes, that's all I would say. I'm looking down at my phone because I had written some notes down. So yeah. Yeah, that's what I would say, son. That's what I would say. Yes. I hope this video helped you all. And until next time, you guys be blessed and you guys take care. Bye.